Four, three, one. We are live now.
So, good evening, everyone. On behalf of Rajasthan Orthopedic Surgeons Association, I welcome you all for this another master class in hand surgery. And today's topic is very interesting. It's malunited fracture lower end of radius. We have a good galaxy of faculty at from national level. Dr. Shailesh Gupta from Indore and Dr. Anil Bhat from Manipal. Both are very renowned hand surgeon, very good in distal radius fractures and hand surgery and dealing the complications. Then we have the ROSA faculty with us, Dr. Shashi Agarwal, Dr. Ashok Khandaka, Dr. Jayant Sen, Dr. Narender Saini, and Dr. Manish Dhankad as panelists. We have our Rajasthan Orthopedic Surgeons Association President, Dr. Kishore Raichandani, and President-elect Dr. Jaswant Singh with us. And President of Jaipur Hand Surgery Association, Madam Dr. Punia Patni. I welcome you all for this very good webinar. We are conducting it very regularly. Now, I formally invite the Rajasthan Orthopedic Surgeons Association President, Dr. Kishore Raichandani, to inaugurate this webinar and start the proceedings of today's webinar. Over to you, sir.
Thank you very much, Rahul. Thank you so much, everyone. And it's our privilege to see that it is the 17th webcast is being done by Dr. Amit in hand surgery. And such a renowned faculty he has arranged. And we are very lucky and fortunate to have these big people for such an important topic, the radial distal radius malunion. It will be very, very interesting for all of us. And I would love to start without wasting much time, and let's inaugurate and start the proceedings.
Thank you, sir. Thank you so much. Our today's moderator is, as usual, Dr. Amit Vyas. I'll hand over mic to him now. He will introduce the faculty and start the today's proceedings. Over to you, Amit.
Yes, sir. Thank you, sir. Good evening, everyone. So, I'm highly thankful to ROSA officials to give me this opportunity to conduct a webinar on this complex subject, malunited lower end radius. As you all know, malunited lower end radius having a lot of decision-making things, means it may present with the stiffness of the hand. There may be some. Sometimes it may be acceptable, some functional complications may be there. So a lot of problems are there. So for this, we have invited our faculty to discuss on this subject. So for this, today, first of all, we have invited Dr. Shailesh Gupta, sir. Shailesh Gupta, sir, he is senior consultant in hand surgery at practicing at Indore, and he has long experience in hand surgery for about 21 years. He is practicing, and after doing his basic degree, he has fellowship from the Louisville, then in wrist arthroscopy fellowships, and he has 125 lectures delivered in his career. And so welcome, Shailesh Gupta, sir. Dr. Anil Bhat, sir, needs no introduction. And sir, he is associate dean at KMC Manipal, and he is professor and head of the hand surgery unit and orthopedic department at KMC Manipal. Sir, presently, sir is secretary of Indian Society of Surgery of the Hand. Sir has long academic career. I welcome sir. And after that, we have Dr. Sasikant Agarwal, sir. Sasikant Agarwal, sir is retired from the SP Medical College, Bikaner. He was a head of the department of orthopedics at PBM Hospital. Welcome, sir.
Good evening.
Yeah, Dr. Ashok Khandaka, sir. He's director and senior consultant at Khandaka Hospital. Welcome, sir. Jaipur.
Good evening to all of you. Namaskar.
Yes. Dr. Jayant Sen, sir. Sir is senior consultant at Santokba Durlabji Hospital, Jaipur. Welcome, sir.
Thank you, Amit.
Yeah. And Dr. Narender Saini, sir, he is associate professor at SMS Medical College, and he is senior consultant in hand surgery at SMS Medical College. Welcome, sir.
Welcome. Good evening, everyone.
Dr. Manish Dhankad, sir, he is professor and head at Ananta Medical College, Udaipur, and fortunately we are batchmate during MBBS. Welcome, Manish, sir.
Thank you, Amit.
With this, our ROSA official, Dr. Rahul Katta, sir. Sir is secretary ROSA, and he is working at Katta Hospital, Jaipur. Welcome, sir. Dr. Kishore, sir, he is president ROSA, and he is professor and head at SN Medical College, Jodhpur, sir. Welcome, sir.
Thank you very much.
Jaswant Singh, sir. Sir is senior consultant at sir has owns his hospital at Kota. Welcome, sir. Purnima Patni, madam. Madam is retired professor and head from the hand surgery unit, SMS Medical College, Jaipur, and madam is teacher of all of us. Welcome, ma'am, for the opportunity.
Thank you, Amit. Thank you. Good evening, everyone.
After this, today, Dr. Anil Bhat, sir, he will give one outline how to approach for lower end radius, malunited lower end radius fractures. What are the treatment consideration and decision makings? And after that, Dr. Shailesh Gupta, sir, he will demonstrate some case-based discussion. So, first of all, I would invite Dr. Anil Bhat, sir, to give the outline, how to treat and decision makings in lower end radius, malunited lower end radius.
Thank you, Amit. Is my screen visible?
Sir, yes.
Yeah. Thank you, Rosa, for this opportunity again. It's always like a homecoming when I see all of you. We were just in Jaipur recently to conduct a basic hand course. And it's always nice to meet all of you offline, online, both ways. My brief was to give an outline on distal radius malunion. And this is a lady, 63-year-old lady. Just one second. Right. So she presented here with this kind of a deformity there. And if you see that, that's a classic manus valgus kind of deformity. That's what we teach our residents. She came basically with pain and restricted movements and had a fall 8 months back, treated with the plaster immobilization. This is basically for the residents who have joined. When you present a case, is one of the common short cases kept. You should always demonstrate the the level of the styloid process here like this to show that there could be change in the styloid process. You should also show the thickness or irregularity of the distal radius. Very important. Is my voice clear? Any disturbance?
It's very clear.
Yes.
Okay, right. And you should also demonstrate the restriction of movements, because you have to show, is there a functional restriction? Deformity is one thing which a lot of people come with cosmetic deformities, but disability is what you should be showing, and that is very important for your decision making. And one of the most important movement you have to document is the pronation and supination. Even though we talk of distal radius malunion here, the important joint which is affected is the distal radioulnar joint. So restriction of this movements is what the patient comes most of the times. The radiocarpal or the wrist movements might not be affected much to cause disability. But the moment they have restriction of distal radioulnar joint, then they come to you most of the times. Don't forget the median nerve. Always examine the median nerve. Sometimes they come with wasting like this. They can come with some amount of weakness, which is not seen, or which is patient might not really tell that a lot of times, because they're very slowly progressing kind of a carpal tunnel syndrome, which they might have. So you need to be checking the median nerve and documenting before you take a decision on any of these patients. So very, very important for you to check for the median nerve status. This is the same lady who came to us. This was the initial X-ray. This is what was done. She underwent a closed reduction and a cast application. Conservative management in distal radius fractures actually require a lot of attention. We think plaster application and just leave them alone, which actually causes distal radius malunion. If you operate and you fix them, sometimes you don't really have to, have a very vigilant kind of follow-up. But if you have put them on a cast, you make sure that you follow them for at least first 3 weeks, because that is where, when the edema subsides, the swelling subsides, the collapse happens, and the reduction is lost, and the eventual result is a malunion. So if you see here, this was, I think, probably post 1 week X-ray, I think. Already the collapse is already there. Ideally, she would have required a re-reduction and cast application. By 3 months, this was the status of hers. If you see that there's a gross reduction in the radial height, there's a gross dorsal tilt there. The distal radioulnar joint is incongruent, which basically means that her DRUJ now won't be working. That's why she came with that restriction of pronation and supination, which I showed you in the video earlier. Now comes the option for treatment, where your decision making happens. Just to leave her alone. She was not, she's 60, but then she was very active. She was teaching and she was doing a lot of things, and she demanded that she requires that range of motion. So leaving alone is not an option. Directs is again not an option in a physiologically active patient. Nobody should be doing directs. I mean, that's a destructive procedure. So we should not be just, taking off the ulnar head and then think everything will be normal. No, they will have more problems there. Ulnar shortening, is it an option here? But if you look at the radius itself, that is actually malformed so much, the dorsal tilt, the reduction in height. So again, that might not be the answer to restore the distal radioulnar joint. I'll come to the ulnar shortening later. So should we do a corrective osteotomy? So this is how your decision making happens. What to do with this patient based on her demands, based on her activities. Very, very important to talk to the patient and take a decision, not look at the X-ray. If I just put this X-ray, people might just say directs, or they might say ulnar shortening, but that's not the case here. And this malunions become very, very important for us because many patients come with wrist pain. And here it's not just radiocarpal, the wrist is involved, it's the radioulnar joint. Sometimes even ulnocarpal involvement could be there, range of motion reduction. But what eventually happens is they develop instability, and especially with both distal radioulnar joint and even the carpal instabilities. I'll show that later. As I showed, soft tissue complications could be there, carpal tunnel syndrome, CRPS. These are the things why the malunions become clinical. And in fact, they all majority come with ulnar-sided wrist pain, not the radiocarpal wrist pain, but an ulnar-sided kind of a wrist pain they would come with. So the criteria for acceptable malunion, for a reduction of the acceptable malunion would be that the radial height should be less than 5 millimeters compared with the contralateral wrist. And radial inclination on a PA view should be more than 15 degrees. The palmar tilt, you should be probably getting up to neutral position at least to 20-degree volar tilt. That is what is acceptable reduction, even for closed reduction for that matter. And articular incongruities at least should be less than 2 millimeters. That is what is accepted in a radiocarpal joint here. This is what is based on a population studies, but what is normal for the patient is always, you need to be looking at the opposite side X-ray. So when somebody asks you what is the reduction or a malunion treatment, how do you decide on how much you have to achieve? you should be taking the opposite side X-ray to look for the radial height and the inclination. So that is the next decision-making point of taking X-rays of the opposite side, so that you know what are the indices for this particular patient. If you look at the inclinations of each of us, it could be different, completely different. So we can't be telling 22 degrees is for everybody, or the range is, that's why the range is given always. Height is, they say average is 11, but then it could be anything, and tilts also. So it's very easy to, with the PAC system nowadays, it's very easy for us to calculate these angles and, try to restore these back. So if you see this, this palmar tilt is about 8 degrees here in this patient, even though we talk about, almost 11, 12 degrees. But here it's reverse, it's 17 degrees, it's actually opposite, which is minus 17. So you need to be restoring a lot of these tilts in these patients. The next decision making is, what is the type of malunion? Is it extra-articular only? Or is it intra-articular, also component of intra-articular malunions? Is it radiocarpal or radioulnar joint? Okay. Or is it a very complex metaphyseal plus articular, mixed kind of a, combined kind of a malunion? So each of these will have different decision making when you look at these X-rays. So all malunions are not just one type. There could be different types of it. And based on that, you have to take a decision what you have to do with these patients. Always look at DRUJ. Any malunited patients, the first, your eyes should go towards the DRUJ first. You should look at the carpus, the malalignment, and also what has happened to the joint itself. So if you want to look at the instability, a lot of times we miss this. If you look at the CT scan axial view, you see the sigmoid notch there, and that goes to malunion, and that patient might develop instability. If you look at the radial articular surface, it's absolutely normal, almost maintaining that inclination. But this patient came with severe restriction of movements, and the answer is that the sigmoid notch is the one which had fracture and it malunited, and that the movement of the radius over the ulnar got restricted. If you look at the carpus, so a lot of times when there's a dorsal tilt like this, the carpus slides off dorsally. So this, but then if you look at the axis of the lunate and the capitate there, they are in almost same line. So this is called an adaptive kind of carpal instability. The carpus is adapted to the dorsal tilt, but sometimes it becomes fixed like this. When the carpus goes on sliding and the movements go on, getting restricted, it goes into what is called the type 2, which is more of a fixed kind of a DC deformity. So these patients do, if you do a corrective osteotomy, they might not really do well because the midcarpal joint is involved, where all the wrist movement starts. So that is where you need to be looking at these. And the joint status, what has happened? So in a patient like this, where there is a gross reduction in the radial height, the ulnar has gone and impacted the carpus. So this is ulnar impaction kind of a syndrome, right? And sometimes that can cause a lot of problems. Or there could be a radiocarpal primary intra-articular malunion can go into arthritis also, but much later than a DRUJ arthritis. So these are the things you have to be looking for. And finally, you look at the soft tissues, the median nerve and CRPS, which I mentioned. So there could be a prominent plate, there could be a very bad malunion, and that malunion itself can be compressing the median nerve, or the implants can be pressing on the median nerve. So when you look at all these, then only your decision, the type of malunions, the joint status, the carpus, and the soft tissues. So look at all these to take a decision, and then you define your goals, which basically means you have to reestablish the metaphyseal geometry, you have to align the articular surface, and you restore the relationship at the distal radioulnar joint and midcarpal alignment. And finally, you look at the soft tissues and respect the soft tissue envelope, and also the nerve also, which is going close by. So when it comes to managing these, not all malunited distal radius fractures require surgical treatment. So your decision making for anybody looking at just the X-ray and trying to operate on it, no. You need to look at patient's demand. A lot of non-unions, malunions don't cause any problems. It's just the cosmetic deformity a lot of people would come with. Where is the location and intensity of the pain? How much functional impact and motion loss has happened and the grip strength has reduced for these patients? Of course, a lot of times we do it for cosmetic deformity, which is very gross. Young patients, they would want it, and you have to do it. But also it is for preventing future arthritis and carpal malalignment, and of course the radiological findings itself. So for a corrective osteotomy, the indication would be these: a very symptomatic malunion with pain and weakness and cosmetic disturbance, restriction of movement, especially palmar flexion, because a lot of time these are dorsally tilted and dorsally malunited, and palmar flexion is grossly reduced. DRUJ, if it is incongruent, definitely you have to align it, and that causes limited forearm movements and of course carpal instability itself. So these are the patients you have to talk about corrective osteotomies. And radial shortening is a predominant component in the malunion. So osteotomy corrects this, especially almost you get 1 to 1.2 centimeter of lengthening you can get. The volar tilt in sagittal plane you can achieve, and you can achieve the radial inclination in coronal plane, and you can also achieve the rotational deformity correction. So you should imagine that this is a three-dimensional kind of deformity. It's not just, radial height is reduced. All these in sagittal, coronal, and axial planes, and in the length or the height, all have to be corrected when you do and radial shortening is the one which will cause most of these things. So osteotomy has to be planned in such a way that it has to be parallel to the articular surface, and then you have to do this. Traditionally, we have been taught that dorsal osteotomies, wedge osteotomies like this would be good. But then once the volar blocking plates came, a lot of us shifted to volar plating and volar osteotomies and approach from the volar side, and you could still do a good job. And earlier there were a lot of complications with the dorsal plating. Now, of course, we have low profile plates, but at least I've personally completely switched over to the volar kind of corrections. And literature also supports that there's not much of differences. In fact, rate of complications, hardware removal rate was much more in the dorsal osteotomies, but low profile rates are available, but similar outcomes between volar and dorsal osteotomies. Personally, for me, I do a lot of this distraction type of osteotomies where I completely distract this, and this helps in three-dimensional correction of all these deformities. And you can sometimes do a classic hinge type of osteotomies, but when you're going on the volar side, sometimes the volar lip can come in the way when you do the dorsal wedge kind of an osteotomy from the volar side. But a distraction osteotomy sometimes is required when we have gross reduction in the radial height, and then you will have to do this distraction osteotomy, and the gap can be filled with graft or sometimes can be left alone. So there's a lot of literature supporting no need of grafts because this is a metaphyseal area, and the whole of these plates are fixed plates, fixed angle plates. They provide a lot of stability, so you don't really have to put in a graft. But if the gap is too much and you've distracted a lot, yes, it's safe for you to put it. But otherwise, some small gaps like this can be left alone. And I've been practicing without graft for the last few years now, and we have not had any major complications. So very, very important in your decision making is also your pre-op planning of how you do this, and where the basic templating is good enough in dorsal osteotomy or even the volar osteotomy, where you want to put your plate, how do you want to get the wedge here. So the basic principle and steps of volar plating would be, most of the times I would do with a regular Henry's approach, modified Henry, or sometimes an extended carpal tunnel approach. This was the same lady which I showed you initially, and I wanted to release the carpal tunnel, so we went through this extended FCR approach like this. The median nerve was definitely involved there. So you can see the swelling of the median nerve. And very important for you to see that deformity very nicely, both volar and dorsally also. The dorsal clearance of the tissues here, especially the periosteum and everything, and the fibrous tissue is very important for you to get that correction and to get that inclination and height back. So one of the things we struggle on table would be this. If you don't clear this dorsal aspect, it's very difficult. A lot of times the fracture site, you can go through the fracture site, or if it is very distal malunion, you don't have to do that. You can go in a very good area where your plate can be fixed nicely, and you can do the osteotomy at that point. But if you're doing it early enough, you can actually visualize the fracture site and go through that. Your first wire, just for a templating, I'm showing should be parallel to the joint. And the one which is here in the proximal aspect is basically the way you calculate how much of correction you want, and you create that angle, right? And this is how you place the plate in the same angle like this, so that when you get this down, you get the palmar tilt back. So this is the angle which I want, which has been calculated preoperatively, right? And that's how the plate sits. And once you get it down, your palmar tilt comes back easily here. Okay. even up to neutral or a little more palmar tilt, but then that's how the wedge can be changed or made, or the plate can be made use of, using the plate correcting the palmar tilt in this particular patient. Okay, this is on the volar side, same way like this. And this is the same lady which we corrected, and we got back this height back here like this, and the inclination. So this is again the dorsal tilt she had, and we got it almost back to neutral, almost about 10 degrees here. So it's with the volar locking plates, life becomes easy. This was, I was talking about distraction osteotomy. I use a laminar spreader like this, and distract this so that I get the height back. I put a transfixation wire here so that I hold that distraction. Okay, and then I put on the plate. So this corrects radial inclination, radial height, and even some amount of rotational malalignment. So whenever there's a gross reduction in the radial height, same patient here like this, and then the plate is put, and then the wire is removed here. So you end up with some gap here, both sides. There's no cortical contact both sides. This is the most of the time what looks like in a distraction osteotomy. You can put in a graft, you can wait without that, and at least my personal experience, they all heal nicely in about 3-4 months. It fills up nicely, and they get good movements here. The second type of malunion is intra-articular malunion. This was the extra-articular till now what I showed. The second is intra-articular malunion. So there your approach should be slightly different, because you're going into the joint, rather your correction is into the joint. You need a CT scan to see where the defect is. This was the defect in this patient. And again, so this was one particular fragment, the lunate facet fragment. So that is the elevation of the intra-articular fragment here. Okay. And then push it. And what I do is sometimes I hold it with an extra screw there, only for that particular fragment, and then I put the plate onto that. So that is one way of holding that fragment separately with this additional screw here, almost like a lag screw here, and then holding on to that. Sometimes we have combined malunions like this. So this lady, if you see, the radial height is grossly reduced, it's almost ulnar positive. She also has this big chunk of radial styloid with an intra-articular component which is depressed here. The scaphoid is almost sitting inside that. She came to us with operated outside with a dorsal plate like this, and her thumb was completely stiff, her fingers were stiff, her thumb was not moving, and this is what she came with to us. This was just done recently, and when I opened up, the EPL is completely stuck under the plate here, and we had to remove the plate, and then did a tenolysis of all these extensor tendons, exteriorize the EPL, put the extensor flap over the bone to cover it so that there's no rough edge. Then I went Olar on this patient, did 2 osteotomies here. One is on the radial styloid, and one is here in the metaphyse. So this is a combined malunion. So we had to do 2 osteotomies in this patient. If you see, I've restored the inclination here. This K-wire is holding this radial styloid. I put some stimulant here because I didn't want any doubts with this gap there. So I put some stimulant here. This is the opposite side. We have restored almost similar kind of height and also the inclination in this patient. This 23 degrees, I've reached about 16 degrees, but the DRUJ has now become congruent. And this just last week with this kind of a combined malunion. You can do outside-in kind of a technique in the intra-articular malunions with an arthrotomy, or you can, of course, you can nowadays do an arthroscopic assisted kind of reductions also. People have gone on to do customized kind of things. And one of the decision in planning would be to customize completely for the malunion for that particular patient, and normal corrective parameters by superimposition of opposite side radius. And people, this is from the internet. People have used these 3D blocks here, and then based on that, corrections are being done nowadays. I talked about ulnar positive variants initially. So when do you do ulnar shortening? It should be more than 1 centimeter. Plus your radius should be intact in all its, the height and inclination. There should not be too much of dorsal tilt and all. So decent radiocarpal movement should be there, and painless. But basically we are doing it to restore the DRUJ congruency. So instead of getting this completely, if the radius indices are normal, then ulnar shortening would be a good option. And these kind of patients, they have TFCC injuries. Sometimes you have to check the instability and you have to repair or reconstruct these patients. If patient comes late to you, then if the arthritis is already settled in a DRUJ because of malunion, then we have salvage procedures. So Kapanji's procedure, Sove and Kapanji are teacher and student actually. So this is patient came with the distal radial ulnar joint arthritis. So you fuse the joint, you create a cuff here, which is more of a pseudoarthrosis creation. And we use a AFC, the slip here, so that this proximal fragment or the stump is stabilized. So I use a part of the FCU here and suture it through that through a hole here, so that you stabilize this, so that it doesn't cause impingement of the radial ulnar impingement like that. This is the fusion of the distal radial ulnar joint here with the screw there. You can use one screw or two screws. And directs, when it comes, is basically when ulnar translation of carpus has happened, or there's a lot of radial ulnar impingement, or radial ulnar joint is also involved. A lot of these patients can have ulnar head fractures also. So that is a time I would do a directs. Otherwise, most of the time, if it's only DRUJ arthritis, I would do a Kapanji's procedures. But directs original description is you have to keep the ulnar styloid intact with the TFCC intact here. A lot of people just take off the entire ulnar head, and that causes more problem. Directs has got bad name because of that. If you maintain this support here, they would not cause much problems. And nowadays we use the Kapanji's technique of FCU sling for this in directs also. So that also reduces the radial ulnar impingement here. So adapted from the Kapanji's procedure to the directs also. So in summary, most common complication after distal radius fracture is distal radius malunion. And it leads to both biomechanical abnormalities in radioulnar and radiocarpal joints, eventually going on to carpal instability with midcarpal articulations. And clinically, patients develop instability, arthritis, or secondary carpal instability. Your corrective osteotomy should be aimed at restoring the articular alignment with respect to patient's normal wrist. So always take the normal side X-ray and look at the indices and then plan your management. You can have other options like ulnar shortening for certain indications. You can go for salvage procedures in arthritis like Kapanji's and directs procedures. Thank you so much for your attention.
Thank you, sir, for excellent talk. I would like to ask one question. For correction of the dorsal tilt, do you go means open from dorsal side also? Yeah, you manage it from the volar side as you have shown.
Most of the time it's always from the volar side itself. So first is basically clearing the soft tissues from on the dorsal aspect. Sometimes I use the osteotomy site itself to go intrafocally to clear up all the fibrous tissue, or even go from the lateral aspect and clear up that. And then based on that, so when the dorsal tilt is there and your osteotomy is on this side and you want to get this, so sometimes this cortex might actually impinge to a certain extent. So sometimes you might have to create a little space for that if the tilt is too much. Otherwise, most of the time it comes back to neutral easily. There's no issues with that. If the tilt is really gross, sometimes you might have to create a space for that. That's very rarely it happens. But this clearance is very, very important. This clearance is very, very important for you to get any of these, to get the radial height back, to get the... So we struggle if we don't release the soft tissues. So the secret of correcting a malunion is to release the soft tissues nicely. Your brachioradialis, your dorsal adhesions, because of the old fracture, hematoma, and which has become fibrous tissue. You need to take away the extensor tendons away from your operative site nicely. Once you do that, it starts moving nicely.
So all these things you do from the volar side?
Yes, I have not gone on the open. This is the last case which I showed you was the first time I've opened on the dorsal side, because there was a dorsal plate which we had to remove. And then again, I went onto the volar side. I didn't want to put a plate again on the dorsal side, even though it was open, because of so much of adhesions there and her fingers are all stiff. So we did an extensive, nice stenolysis, covered the bone with the extensor retinaculum. All the tendons were kept out, and we have started our mobilization.
Any other question from faculty?
Am I heard?
Yes.
Yeah, right. Nothing like question, but what I want to say is that during our time, during our PG time, we used to have a lot of malunited cases, and most of the cases used to get relief by a simple procedure as a direct excision. I really feel sometimes that once the fracture has united, malunion means the fracture on the lateral side has united. And I have yet to encounter a case of instability of the radius in malunited fracture, instability of the wrist joint in a malunion. Most of the patient came with a restriction of the movement. And once there is a restriction of the movement, it is very difficult to demonstrate an instability. So they wanted a good movement somehow or other. And few cases, like one of our chief, he was doing osteotomy of the lower end of the radius to correct the angulation and the tilt and everything. And most of those cases, when he did a second operation to correct the angulation and did an osteotomy, they ended up with the more restriction of the movement, with a lot of complications. And if you see the literature, the complication of a conservative treatment is only malunion with little restriction of the movement. But 90% of the complication in the fracture of the lower end of the radius is secondary to the surgery. Be it be infection, be it be carpal tunnel syndrome or a compartment syndrome or whatever you want, a restriction of the movement, breakage of the implants, breakage of the wires and the plates and the impingement of the median nerve from the surgery. You read the complications, the 90% of the complications is because of the surgery. And I still feel that the direct excision is a very simple procedure, will land you in no trouble. That's my opinion. I have yet very little experience of the plating and all these things, but I certainly feel that in plain simple cases where you get not the malunion, the K-wire fixation or percutaneous K-wire fixation is definitely better. So let's see what the other people say. Hello?
Yes.
One more single point. There was a study, there was a peer review. You see, the malunion, if you see the literature, I was just going through the literature since the 2010 or 12, there is very little literature available on malunion. Most of the literature is available before that, because now most of the cases being treated because of the image intensifier and because of the earlier fixation of the fracture, be it be K-wire or be it be plating, the malunion is very rare. And we hardly get those cases, at least not in my practice, and for the last 10 years, I hardly see any case of malunion of the lower end of the radius. And there is a peer review, and in that review, there was no consensus as far as the proponent of the operative as well as a conservative treatment. And this injury, fortunately or unfortunately, usually take place in the older people. And what they want is a little functional independence and little grip strength. I think the only difference is when you get a good osteotomy, or if that heals and gives you good strength, that is the grip strength in the wrist. That is the only difference between the two, where the directs, you have a little lesser grip strength. I think that's my point of view.
Yes, sir. Khandaka, sir, you want to say something?
Yes, I just wanted to, Dr. Bhat, excellent talk on malunions. I just wanted to know, how do you deal with cases in which there is no space for passing screws in the distal fragment, when the distal fragment is too small? to take on the inclusion the distal fragment.
If you're talking of malunion correction, sir, where there is a very distal fragment, which
I'm talking of malunion as well as maybe non-unions also.
yeah. So one of the strategies, see, there are two things. One, there is a nascent malunion when patient comes at 2 months or even less than 3 months, and it's all very still just about quite soft and it's healing up. And there are patients who come very late also, but then we know that the original fracture was somewhere very, very distal. So both times, what I do is if a patient has come early and I know it's a very distal fracture which has become a malunion now, I would just ask them to wait till the bone consolidates, and then I plan it in such a way that I don't have to go through the original fracture site. All I need is a good space for my plate for the distal rows of the screws. So I would do my osteotomy at a different level. So that is the best way of doing it. Otherwise, we end up, if you go with a nascent malunion, which is the patient has come at 2 months or 5 weeks or 6 weeks or whatever, and then you see the fracture line and then you try to go there and try to raise it up, all you get is a very, very soft bone in your hand, and you might not be able to fix it with your screws. So I would wait for it to consolidate, and I would look at how much of space I require for a comfortable placement of my plate, and I would do it in a slightly proximal site, and then get the radial inclination of the height back. So that is how I would deal with that.
Thank you very much.
Any other points?
Yes, sir. But sir, one question from me. Can you hear me now? Hello?
Yes, sir. Yes, sir.
Please go ahead.
See, how much of distraction is acceptable, or where you don't want to put any graft? Is it 5 millimeter, 7 millimeter, or how much?
Okay. Most of our we've just sent it for publication. We have about almost 62 cases now, and we've sent it for publication. So average we have about roughly about maximum would be 8 millimeters to 1 centimeter maximum. So that is where these have worked very nicely for us. Beyond that, we need to be a little careful based on patient characteristics. Young patients and all might do well, but if you have elderly patients, then the bone healing might not be good. I would, like the last case which I showed you, I would put a stimulant or any of these things. We have not only, I think, one patient where the distraction was too much, then we have put a graft. But otherwise, generally they fall into 1.2 maximum. There are a couple of outliers in our study which had a little more gap. Took longer time to heal, obviously, but they all heal. What other thing we have found is where from the articular surface, it doesn't matter where your like sir was asking if you have a very distal malunion. Even if it's at the proximal aspect, the osteotomy site from the articular surface doesn't matter. So that's what we have found. But the gap definitely matters. So the more the gap, the longer it takes to heal. So those are the cases you might have to put a graft. But generally, most of them work out between 0.8 to 1.2. That is the range we have in most of our patients.
So if you have a 8 millimeter or 1 millimeter or 1 centimeter of distraction, but
Yes.
in those cases, you may require the ulnar shortening also.
I mean, as long as you are getting the DRUJ, congruency, I don't think you should be doing that, because ulnar shortening is not a very simple procedure. Most of the time we end up with complications because one is those that it doesn't heal nicely as distal radius. It's not a classic metaphyseal area. Second is we don't have good implants very distally for our patients, especially customized ulnar osteotomy plates are very expensive. So we end up, trying to compromise on different kinds of plates. It could be a lateral distal radius plate sometimes, which I use, or sometimes a kind of a semitubular plate. These are not good plates for ulnar shortening, and they might end up with non-union. So I would avoid that simultaneously. I would try to get as much distraction and get maximum correction from the radius itself. Otherwise, I would just do an ulnar shortening osteotomy. I would not do anything with this radius, as long as the radius indices is quite acceptable. It's not grossly dorsally tilted, or those kind of things. Then I'll have to do both together. But otherwise, I'll just do ulnar shortening and be done with it. That's how I would approach.
Which in a fresh case, where there is a fracture of distal radius with fracture of the head, or rather you say just distal ulnar fracture. Most of the time, the reduction doesn't come, and it is very difficult to reduce the fracture and to catch hold of that fragment. How do you fix the distal ulnar fractures along with the fracture distal radius? Which plate or which implant do you use?
Yeah, a lot of times we spend a lot of time on distal radius, and what happens finally, we end up just putting a K-wire into the ulnar, and it invariably goes for non-union and causes problems. And as you rightly said, your reduction doesn't come easily unless you restore the DRUJ relationship. So your ulnar reduction has to be perfect. So you'll have to actually spend more time on ulnar rather than the radius. The moment you fix the ulnar column nicely, your distal radius reduction comes very easily. So I would put a good plate. That's why I said sometimes I use this L-shaped kind of plates from the lab for the dorsal plates which you use for radius, or the radial column plates. So those are with the locking plates. So those are the ones I would use for the ulnar also, contour it a little, and then I would use that. A 3.5 system plate becomes really proud there and causes irritation. So one of the other strategy would be putting it on the radial side. So you don't put anything subcutaneous, but you would put it on the radial side, the ulnar. It's a little difficult to put in your screws there, but that is one way of giving a very stable fixation. So ulnar needs to be fixed nicely. A lot of people just pass one K-wire from the olecranon after reducing this, but invariably one might go for non-union, other will go for malunion. So my experience is spend a lot of time on ulnar fixation. That is the key for your distal radial ulnar joint and eventually distal radius also.
So to fix, what is the sequence? To fix the radius first or to fix the ulnar first?
I open both. I look at the reduction of both, right? And then see, basically the ulnar is the static pillar there. The radius rotates. So your primary aim should be to get the ulnar column first, right? The radius rotates around the ulnar. So that is why you need to fix the ulnar column first and restore its normal length and then go on to the radius.
Thank you, sir. Thank you.
Thank you, sir.
Okay.
Sir, one question from my side. It's last question and silly question. When you would not like to operate, because you have demonstrated very good surgical techniques in the malunited fractures, when you decide not to operate in such cases?
Sir, in my practice, people come only because they want something, because they are disabled. So they see a lot of these old ladies, when they come, they say, I just want to tie my hair. I just want to wash my face on my own independent. They're very demanding. So these are the ones. See, otherwise they wouldn't come to you at all. I mean, at least for me, because if it is purely a cosmetic thing, malunion is there, but they're doing most of their activities. There's no pain. You should not be touching them. My first sentence in my slide was, not all malunions require treatment. So majority of them actually don't come to you. As sir was telling, a lot of these patients might not come to you only because they're fine. They're asymptomatic. They're doing all their work. But moment it becomes difficult in an elderly patient for their ADLs, they're staying alone, they want to be independent, they will definitely come and ask for change. If they come, then they might come with a lot of pain. Younger patients, if they're badly, it's fixed, the distal radius, they have TFCC kind of pain, ulnar-sided pain, they come to you. So these are the ones which come to you. Otherwise, I would never touch. These patients come, they show their deformity, cosmetic deformity. I look at the range of motion, absolutely no pain, no restriction and all. I tell them, just leave it, nothing will happen. If at all pain comes, come back to me. Otherwise, just leave it alone. That's what I would say.
So, thank you, sir.
So the take-home message for younger surgeons is all the cases of malunion, choose carefully.
Exactly. It's always the disability of the patient, nothing else.
Thank you. Thank you, sir.
So I'm going to invite you for the another part of this webinar. Initially, we planned like this that we will discuss a variety of cases. Then we thought we should give one outline. Then we will do the case discussion. So I will invite Dr. Shailesh Gupta, sir, to put some clinical scenario. So it can be interactive and some inference we can draw. Thank you, sir. Please share your screen and start.
Thank you, Amit. And thank you, Anil, for such an enlightenment of the subject. And it made my life much easier. So meanwhile, you were giving the talk, I reduced my slide load by 6 slides because you already covered that point. So I am still learning a lot, and I learned today a lot from you and will continue to learn. There are certain things which I admitted that lot of time I go by the eyeball judgment. When I plan everything, but when I go to operation theater, I am the only one who is taking care of all these things. We don't expect our assistant to do the same thing as professor is doing. So when it comes on the Siam imagination and everything, the eyeball judgment becomes very important. Still, in many cases, a conventional way of plating also helped me. And so I'll explain and I'll share my screen. Thanks again, Rosa, Amit, and my seniors for inviting me for sharing my experience. And actually, it helped me. Sorry. Actually, whenever there is a talk has to be prepared, it helped me a lot in retrospective analysis of what I am doing. So this talk I have prepared as if it is my journey. So I started with the first case of malunion which I did and how I matured, what changes I have made, and what changes I wanted to make, but still going in the same way I used to do 21 years back. So it's my journeys from starting with how does it go. So our basic learning always start with the basic fixation. And then the training should be that you go with somewhat difficult fixation and then a really difficult fixation, and then you touch the malunion and non-union. But in our Indian scenario, it becomes reverse of the pyramid. And if you are something like a trained hand surgeon, so-called, which you say that in 1 year you have become a trained hand surgeon, then people will suddenly jump with the very, very difficult case in beginning of your practice, like a painful non-unions. So the case 1 scenario. This gentleman who has a 3 or 4 month old volar Barton malunion. As per our classical teaching, he was not having any pain. He was absolutely fine, no complaints of pain. Then I asked him why you came to us when there is no pain. He said, I cannot lift the 120 kg weight because there is a limitation of dorsiflexion. This is my profession. He is the professional bodybuilder and that is his profession. There is absolutely no pain. What he want is a full dorsiflexion. So when he lift up the weight in a 100 kg, 120 kg weightlifting competition, he could lift it. Otherwise, his weightlifting capacity has gone to 60 kg or almost 50% of the. He was not bothered at all about the deformity. There was absolutely no pain. So this was the first case of my practice which I have to encounter in management of the malunion. And then the demand of the patient was too much to fulfill. And I took this patient, accepted the challenge. At that time, there was only conventional plate available. But when you see my maturity of doing the malunion in over the period of 20 years, you will still feel that I'll still use a lot of conventional plate. So what I did was I did the intra-articular osteotomy. The key was lateral, good Siam view and a curved osteotome, a broad curved osteotome, almost so broad that it is going through the malunion in a horizontal direction. So gradual osteotomy putting putting a distractor after the osteotomy, give the time for the soft tissue to strengthen out, wait for 10-15 minutes, and then put the plate. Now, looking at the demand of the patient, his muscles were so powerful. I was afraid to leave it alone. I thought a load of carpus, and especially the flexors, which are very strong anti-gravity muscle, if I leave it, the screw might fail or my osteotomy get displaced. I continue to put him on the external fixator as a mass safety device. So this is the 16-year follow-up which he recently, about 6 months back, sent him on the WhatsApp. So he is still continue to do his bodybuilding exercises. I got a permission from him to show his video on this webinar. So he's continue to enjoy that. His implants are out, and after the surgery, he went and won a big challenge of the North India bodybuildership. So case 2, another one, a dorsal angulation. As Anil pointed out, that initially a lot of osteotomy was done on the dorsal side. There is a dorsal angulation. So he was a brother of a general surgeon. Again, a new in practice. Everybody jumped to me that they want to get it corrected. So after that was the initial X-ray, which was not followed as it should be followed, and he ended up into the nascent malunion. A lot of ulnar shortening and a lot of pain. He is an insurance agent. He is not able to drive the motorcycle. No pronation supination. Again, earlier, not much experience. I started. This was his deformity, and then what I did, I opened it from the dorsal side, corrected as much as possible. There was a precondition applied by him that I don't want any procedure on the ulna. He was brother of a doctor, probably afraid of anything fracturing a normal bone. So he said, whatever the correction is there, I will accept it. And this is around 3 months, 3 years follow-up, what he has achieved on the pronation supination. He just wanted to have a pronation supination and no pain on the ulnar side. Though there was still some DRUJ instability, but because of the demand of the profession, he continued that, and he never ever came back for any further procedure. Though I meet him socially, and he never complained of anything. Again, earlier stage of my practice, the gentleman came with a 3-month-old compound, 3-4-month-old compound injury with a completely stiff hand, and this is the distal radius position he is having. So again, there is no choice to accept the challenges. So I decided, let's build up the column. Now, once I built up the column, we'll do everything and anything for the tendons and getting the range of motion, and maybe some capsulectomy of the MP joint. So I just opened from the volar side, and to my surprise, the things came very nicely. There was already a loss of ulna because of the old compounding injury. Again, somehow the fixator gives me a peace of mind. So I put a fixator just to prevent any collapse if it happens. And then once the bone united nicely, I went and did the tenolysis, and just tenolysis and manipulation of MP joint gave him a reasonably functional hand. So after doing all these cases, people started approaching me for the more malunion, that okay, let's dump all this to Shailesh, it will be much more easier. So this is again a district champion wrestler, lives in Indore. Look at the malunion. Look at the distal radius line. This line which I have shown marks the lip of the distal radius. And the look is as if there is a radial shortening and relative ulnar lengthening. But look at this. This is the distal dorsal lip of the radius, and this is the volar. So there's a broadening of the lower end of radius, and there is a proximal migration of the whole of the carpus. So this is his deformity. Again, he wants to pursue his career as a wrestler. So we went and got a CT scan. We got the exact picture. How much is the union and what is going on? So what again we did open reduction, volar approach, curved osteotomy, lateral view under constant guidance of the C-arm, correct it, do the intra-articular osteotomy, correct the malunion, put the plate, and again, I don't know, people might not agree with me, but I put the distal radius as a neutralizing external fixator for 4 weeks to have a peace of my mind. Yes, in addition to that, I put a bone graft in both the case, the first bodybuilder also and this wrestler also. So these were the cases, and this was his final follow-up. He never came back for plate removal, and the plate was the volar, but typical T buttress plate was very well fitted. So he never came back and never had any issue with that. And look at the DRUJ. It is almost normal. There is no subluxation. There is no DRUJ. So it is the false interpretation of X-ray you may have over looking at this X-ray, just looking at this X-ray, that there is a great radial shortening, and you have to be careful in making any decision like that. So another lady with a deformity and lot of pain. Again, the very important thing in all these cases, where whatever non-union, malunion I am talking, there is always indication of the doing surgery. They never came for the cosmetic deformation. There was not necessary pain, maybe professional demand. So that lady was having a lot of pain. So that was her collapse, and then there was not much lower end of radius has been tilted dorsally or volarly, but there is a lot of shortening. The ulnar prominence is there. Again, I got little more mature. In this case, open from the volar side, put a tricortical bone graft. That's the answer to Professor Sir who was asking that if there is not sufficient place to put the screw. Here there was not sufficient place to put the screw. So what I did, I put the bone graft, and it helped me as an internal fixation device. The bone graft were jam-packed, and the plate was just to put in such a way that it doesn't, the bone graft, which was a little relatively a way shape, doesn't come out volarly. And then definitely a K wire was put, which is not shown in this X-ray because it has been removed at 1 month follow-up, and this was her final X-ray, which was showing that. Later on, I asked her for the plate removal because I was feeling some synovitis at the FPL, but she refused because she was not having a symptom. There is a reasonable correction of the radial tilt also. And that's her function. There is some restriction of the palmar flexion and dorsiflexion. But what she was suffering with the pain, ulnar-sided pain, difficulty in activity of daily living, she is much happy with this moment, and all the activity of daily living is going fine with her. So again, the question has already been asked: do young patient with malunited fracture of distal radius fracture innovatively develop symptomatic post-traumatic osteoarthritis? It's a milestone paper. The question has been answered by Anil very nicely, but this is a milestone paper which has been conducted by Nottingham University Hospital. What they did was, between 1960 and 1968, they searched the registry in, I don't remember which hospital of UK, and then they did the average 38-year follow-up of the patient who were alive and who were treated for the distal radius fracture at that time, and they all were young. So in less than 40 years of age, and there was no plate fixation or any of the fixation method going between 1960 and 1968. They find out the malunion of the distal radius is acceptable at most of the time. And despite deformity, they are doing very well, and majority are on an average having a grip strength of about 90%. But it is not true with the non-union because of instability associated with the non-union. And this is the case of this lower end of radius non-union, which was operated elsewhere by external fixator application. Here I won't blame the external fixator as a implant. It was not the failure of external fixator. It was the failure of surgeon in applying the proper external fixator. So he was having a very painful wrist range of motion. He was not able to do anything. So when I opened it up, there was a frank non-union. That was a originally applied external fixator elsewhere, and not a finer attention. Finer attention was given to the finer details. Ideally, when you want to put the external fixator, it should be augmented external fixator. The primary stabilization has to be done by K-wire, and then you augment, as it has been mentioned in the Green's textbook of hand surgery. So that was his deformity. And again, conventional plate, long back, 15-year follow-up. I know him very well. He's doing still very well. Not gone for any of the implant removal. No bone graft, nothing was there. Just correct the malunion, just correct the alignment of the distal radius, and everything healed in good time. No physiotherapy, nothing was required. Although I have included it, is just not exactly the distal radius fracture, but it is a lower fourth of the radius fracture, which was treated like this, went into non-union, and we put a non-vascularized fibula. And now, fortunately, when I did the surgery, he was a 12-year-old boy. Now he has become a lawyer, and everything united, went fine. And I don't have the follow-up photograph or X-ray with me, but it was an interesting case, and good non-vascularized fibula can work very well in this type of situation. So another non-union, 38-year-old male, no past medical history, 2-year-old problem, operated thrice in the past. My biggest challenge was his photograph, and obese, no money. He is guard at some building, and I have many challenges. How to start, where to go, what implant to be used, whether there is any use of any implant. And the first challenge I was having was how to get rid of this patient. And when there was always thought in my mind, whenever I deal with a non-union of lower end of radius, which is extremely rare, if given a choice, the bone will try to unite, but it is unusual. But anyway, I thought at least I will correct some deformity. I will excise something. Then I'll give him some brace. He's a guard. He will be able to do his just thing. So something like that in my mind. And again, there is not much distal radius, distal part to fix any bone. So again, my favorite, I started putting, corrected the deformity, took out lower end of ulna as a direct procedure, and then put some bone graft from there, put some K-wire, not happy with the surgery. And then I thought at 6 weeks, fixator remove and the brace will be given. And that's what I've been done. And patient was reasonably happy. Okay, some deformities correction is there. There is enough of fibrous union. I am not sure about bony union, but some callus, something is there. So patient was happy. At least he got something. I was happy. At least deformity is corrected. He's not complaining anything. And then in one fine day, almost at 3 months, he gave me a call. There is a cluck sound from my forearm while I was turning on the bat. The nightmare came through. I thought there is something wrong. So the nightmare came to me, and there was a fracture through the pin track of the external fixator side. What I have been traditionally taught that at 6 weeks, everything whole should heal. Even when you take out the plate, you don't immobilize or doesn't put any weight, at least for 1.5 months. Then you allow all gradual activity towards normal. You feel that in 1.5 months, everything should improve. But here the pin were 2.5 mm. So I was worried what to do. So I don't wanted to take the blame. So I thought, let's have an endocrinologist opinion. At least if we find some reason for breakage of bone after 3 months of pin removal, then we'll consider, at least we'll have some answer to it. And then the endocrinologist started history, detailed history, and then he did the hormonal assessment, and then he find all hormones governed by pituitary is going down and down and down. And then he imagined, he took the MRI of the brain, and it was a sella is empty and thin waste tissue of pituitary parenchyma is noted lying against the floor of lateral wall. And then he diagnosed that it's a case of empty sella strategica syndrome. Okay, so the previous 3 surgeons were blamed for doing the lousy work, they were not responsible. It was not the hardware or surgical procedure. It was the body hormonal imbalance which was responsible for complication. And again, I was not responsible for pin track fracture. It was the not availability of enough of the testosterone and other hormones which were responsible for this thing. So we started the correction of the hormones, started with this testosterone injection, and after 3 weeks, we plated again. And look at that. Converting, there is a bone was so solidly united. So where we have started, and he's very, very, very happy with all the powers he got. There is no pain, plus his body got rejuvenated after getting all the hormones. So here the converting pathological situation to physiological environment is the key. It's not the surgeon or its armamentarium which was causing non-union or helping in the healing for the non-union. So bone was begging to unite, give me my anatomy with physiological environment, I want to unite again. So as a surgeon, I learned the lesson always that we should just not think of anatomy as a surgeon, but we should think of anatomy and physiology. So you should have the knowledge and fusion of all the subject together to execute the best for the patient. So this was operated elsewhere primarily. It was to me, it was not exactly a volar button. It was a sort of a part of a radiocarpal dislocation. Definitely there was a volar button element also. And that was the plating done elsewhere. And the surgeon was very happy that I have done the volar button plating very well. But look at the follow-up X-ray. The lunate is completely shifting anterior. There is an element of radiocarpal dislocation. The fragment which was supposed to be caught by this plate is not being caught by this plate. So AP, they were very happy that the plate is nice, but they were failed to recognize the carpal subluxation or dislocation. To me, it was a variant of radiocarpal dislocation which was missed. Look at the follow-up X-rays they were having. Came to me with lot of restriction of movement, with pain and lot of expectation also. So with cooling down his expectation, making him realistic approach. So I did was fix the radial styloid. I plated him, corrected the carpal subluxation and hold the fracture very nicely with the plate and neutralize always. And this was the follow-up which I got. I'm very happy. What he was initially, he's much better, but in this particular case, I have to really bring down his expectation to realistic. So he's having around 60-70% range of motion. It is not the X-ray which will determine the range of motion. Not the only thing is the X-ray. You have to understand, because of radiocarpal dislocation, subluxation, there was a lot of soft tissue damage to the capsule that will determine its final range of motion. So again, lesson learned in this case. This case is out of sequence. What the cases till now has shown is from the beginning of practice, next level. So yearly I am doing my thing. This is in that particular last case contest. I am showing this patient. I started doing this Malunited correction, and then when I fixed the plate, I realized that still the fragments are moving inside. So keeping all the ornamentarium, like 2 mm screw, 2 mm additional screw I put into the distal to the plate area, and again not crossing the watershed line, and an excellent outcome with this. So these were the screws which has been additionally placed, because I realized that the fragment is not nicely picked up here. Yes, I do agree that here a nice volar locking plate would have been a much better option. But anyway, fortunately it has a this 2 mm screw has hold the things very nicely. So following that sequence, 12-year-old female, daughter of very good friend of mine, met with a school bus accident, had a one-sided, the opposite limb as a compound elbow dislocation with brachial artery injury, which was operated by me at that time. The opposite limb was because she was admitted in somewhere else, so I was not having own control. So I just did the brachial artery repair, reduced the dislocation on the opposite hand, and this was operated by the opposite team. That was the other team on that same hospital. That was the original injury she was having, and then some nail was put, and then no palsy was there, and she came with 7-month-old, very painful deformity of the wrist, and clinically it's a non-union. And then I thought I will do something for her. A very good friend of mine, 2 batch junior to me. Then I discussed everything. He was a general surgeon, so he said, just go ahead, whatever the best you want to do it. And she is just 12 years, so I wanted to save the epiphysis. I was not sure about what is going on with this infection the epiphysis is doing or something. So a barely 2 screw I could put the bone graft, corrected the deformity. Then again I thought I'll be happy with what I am doing. Unfortunately, as the डर था वो सामने आया, that unfortunately she got infected. Again, sometimes it becomes difficult to convince a doctor's family that don't give the antibiotic, go for wash or something. So they continue on oral antibiotic, and unfortunately she went in. She got very emotional, and even I was getting emotional. So they opt for going to Bombay. So they went to Dr. Warrior sir, and what he did was he took out the implant, stabilized the fracture, and the epiphysis was already fired by that time. and put some antibiotic beds on that. So he used the dissolvable beds. So once the beds start dissolving at 6 weeks, he said we'll just keep the fixator for a little more time. Let soft tissue stabilize first, and then we'll do the vascularized fibula or something that time. So they waited, and at 10 weeks we started seeing some callus. And this is at 4-year follow-up. No further procedure was required. No further procedure was required. And you will be surprised that there is no limb length, no bone discrepancy. Both the epiphyses were fired. And there are some theory, there are some paper which has been published. The role of dead bacterial stimuli in inflammatory driven bone formation. So once the infection is clear, the dead bacterial body shell encourage the osteoblastic activity. So that helps in the formation of the bone, regeneration of the bone. And look at her follow-up. There is no limb length discrepancy, blazing and disguide. Her opposite upper limb also has some injury, and because of growth of the epiphysis of that upper limb, the opposite upper limb, there is a natural limb length compensation. So there is no limb length discrepancy. She is doing very well now, and she is almost 19. I think it was done in 2017. Yes, I still remember the first happened accident on 7 January 2017. So it's a COVID period. He's a renowned dermatologist. My senior has a volar Barton fracture. Look at the date. The date of injury is 28/6/2020. Diabetic, not willing to get operated. Absolutely refused for any surgery. So he is not in Indore, but live near Indore. So he underwent a close reduction. Whatever the best orthopedic surgeon over tried, and they reduce it, and put him in the above elbow plaster. So at 1 month, he came to me with this position, not so bad, and nothing, not willing for any procedure. So I took out the plaster and I examined him clinically. Not a very bad deformity, not good bad subluxation, not a very bad range of motion. So in an intelligent cooperative patient, we did a counseling and then explained that if there is anything, we'll do the intra-articular corrective osteotomy. Otherwise, meanwhile, you try, let the COVID settle down so that you will have a lesser risk because of your diabetes. And then of course, we took the CT scan before we make any judgment out of it. And this is at 1.5 month follow-up, maybe more, I think. Yeah, it was a 28th June, and it's a July and August. So yeah, it's a 1.5 month follow-up. And then 3 days back, I called him. How are you doing, sir? Then this is what he said. He is able to do all this type of activities, continue. And this video is shared with his kind permission. He is doing. The left wrist was the original injured wrist. So that's all, and he doesn't want, and he is doing. So sometimes the nature defy what we are thinking. So the second last we did about a year back. This was again a patient with having a radius fracture, shaft fracture, ulna fracture, lower end of radius fracture, and he was operated in periphery and went into this type of situation. That was so, and landed up with me. So what I have to do is, so I decided to open each and every aspect, lower end of radius, correct the ulna, and do whatever is necessary. So I did. I I took out the, I opened the radius first, do the bone grafting, plating, K-wiring, and then, as Anil pointed out, the ulnar osteotomy is not so difficult. So I have to align the ulna very well. After doing the ulnar shortening, I was able to align the ulna and put the fixator for 1.5 months. It was not having enough of space. I was not very sure that this small bone will, distal portion of the small distal radius will roll my load of the plate, and plus there was long standing soft tissue tightness. And this is his follow-up at 1 year, and we have removed his plate, and that is his video. And he's back to his work. His all other plates also removed. So last case, already had a K-wire fixation which collapsed in a 25-year-old young lady and came to me with severe pain. Features of RSD, which I don't believe it was RSD. It was because of severe pain. She was not able to do anything. So corrected, bone grafted. I don't know. I still do a lot of bone grafting in malunion correction. I'm still not able to get the courage of not doing the bone grafting. And this is, she's under the follow-up. So it's only 2.5 weeks, 3 weeks since the surgery. So long-term follow-up is not available. Thank you very much for patience listening. Over to you, Amit.
Thank you, sir. Thank you, sir. Thank you very much for delivering such clinical scenario, and it was quite informative. I would like to ask faculty to comment or ask questions if they have.
Very nice presentation, Dr. Shailesh.
Pardon, sir?
Very good presentation.
Thank you.
And
Thank you.
you have kept the records well.
Thank you.
But I'll start. You introduced this lecture was introduced by my decision making is mainly based on the eyeballing.
Yes, I do a lot of decision making on table before going for the surgery. But when I look at the CM, it's mostly the eyeball. I'm honestly accepting it.
So you just compare on the first X-ray, on the first your presentation. Hello. I'm not getting. If you see the lateral view, where is the carpus bones and is the alignment in the lateral view?
Yes.
If you see the carpal bones, whether they are aligned with the radius or not.
No, they are going with the volar button fracture, correct?
So in the first X-ray, in the first case, there was no alignment between the carpal bones and the radius. Number one. And in the last but one X-ray where the one person was pushing up, there the carpal bones, though that there was a deformity, but there the carpal bones are aligned with the radius.
Yeah, but in both the cases,
OPD you decide. In the OPD you can very well decide whether the carpal bones are aligned. So where the carpal bones were aligned, that's why he was doing a good push-ups. Whereas in the first case, the carpal bones were not aligned. So that was a good decision making on the eyeballing only. This is the final comment on you.
But both the patients' demand were extremely different. The first patient was a professional bodybuilder. He was not having a pain.
But that was not compatible.
Yes, not compatible with his professional career.
But here, there was an alignment.
Yes, agreed.
So this was quick.
So if I would have seen that doctor first time, I would have offered a surgery. That's what I will do for the volar bottom.
Okay.
But it's fortunately you got a good outcome. You may not be getting a good outcome of one good case of volar button fracture having a good outcome, non-operative, doesn't signify that it will be a rule for the rest of your life in all the patient. Because there are a lot of forces, especially the flexor muscles are much stronger, it's anti-gravity muscle again, than the extensor. So there will be always be a tendency to get displacement of the volar button fracture further. Yes, but your point is very well noted. Very well noted.
Dr. Shailesh,
Yes.
you normally use an external fixator in all the cases we have shown.
Yes, it's all very complex cases.
They are very complex.
Yeah, I somehow feel that in private practice you get only one chance. Yes.
And what is the average time period you feel when they get a useful range after removal of fixator?
Around 3 to 6 months useful range. And I'll be sharing you surprising observation. I am not having a physiotherapist since last 5 years. And believe me, a few more minutes in my OPD in all my patients is having nowadays surprisingly better outcome without therapist. But
what is the key you teach them?
Key is biomechanical feedback. That whenever you contract one muscle, the antagonistic muscle has to relax. So if you contract biceps, tricep has to relax. So the elbow movement is not coming. You don't concentrate on elbow thing. You just concentrate on the biceps. So the triceps will automatically get reflexed. Otherwise, there is a rigidity. Any therapist is doing something flexion, extension, the brain is not working. Plus, lot of physiotherapy assist equipment like we get from Bombay from the Dattu surgical. So flapper splint, reverse flapper splint, outrigger. We we have our own splint workshop. So we devote lot of time on that. So I'm more happy because either therapists do too much or too less. Both the things are dangerous. And maybe low volume of practice is making me to supervise all this thing. I may have a large volume with large department. I will not be able to do it myself. It's a pure private practice, no institutional attachment. So I am responsible for all my patients. So yes.
And majority of your cases were quite tough cases, huh? So, how many do you think will require a Sue Kapanji along with the correction of malunion?
I have not done so far, or I may not have encountered. Total, I was looking at my whole 21 years record. I had around 24 cases of malunion, non-union combined together. I have not done Sue Kapanji for distal radius malunion. Yes, I have done for DRUJ, volar DRUJ dislocation, old volar DRUJ dislocation. One. And one I don't remember. So 2 Sue Kapanji procedure I have done so far, 2 or 3.
Okay.
Plus one thing is, if there is a non-union of distal radius, try to find out the cause. You will find out some cause. Either it's iatrogenic or infection and hormonal. Recently, I came across another radial shaft fracture, 6 months following the external fixator elsewhere. And we studied that patient again based on our experience of that very deformed wrist. So we went straight forward, go to endocrinologist. He had a chronic testosterone deficiency. We corrected. He started on testosterone injection. We put the plate, the bone united. His clinical depression has gone. His family life has improved like anything. So total 3 cases of in my life, 3 cases I could diagnose having a testosterone deficiency induced osteoporosis, or you can say non-union or pathological fractures.
This was a good eye-opening case.
Yes, very good eye. And it all happened accidentally. I never thought that it could turn out that. It's not that I was just wanted to find out some clues so that I don't get the bad reputation.
So I want to clarify from the faculty, if you are getting one malunited lower end radius and simultaneously patient is having stiff fingers.
Okay.
So how we will proceed? First work on fingers and then correction, or
I would still try to sense somehow whether the stiffness is primary because of wrong plaster application, not able to do that, there is any painful focus. If I can get some clinical sense out of it, I will correct the painful focus, and majority of the case the movement may come. And if at all, I can put the wrist block and mobilize the finger. That's a very easy way. And the patient, then we will know that the cause of the thing is there or not. Plus, hidden carpal tunnel syndrome in a malunited distal radius fracture should always be considered. There is a bulkiness into the volar aspect. So that will also should be considered. It can just present as a atypical carpal tunnel, can present as a hand pan. A difficult question to answer in a straightforward line. Maybe multiple visits with the patient. Yes, ask them to come repeatedly and see her psychological status also. They are all depressed also because of trauma resulted into malunion, resulted into stiffness, and they got a negative psychosomatic feedback. So talk to them, correct their depression by psychological counseling, not sending to psychologists, but talk to them, encourage them, and if they are cooperative, proceed. Again, non-cooperative patient, you can't do anything.
what sir you would like? Yes.
Yeah. So these patients come probably at 2 or 3 different timelines. So the first scenario would be where they would have been put in a plaster for distal radius, and they have developed stiffness because of the plaster itself. Second scenario where I see patients with stiffness would be when they have a CRPS kind of a picture. And the third would be like this case which I showed in the last, could be sometimes related to implant related, where the tendons have been adhered both flexor side or extensor side, depending on where the problem is. So based on these things, you'll have to take a consideration. Malunion is never an emergency. Malunion is not an urgent thing to do.
Yes.
Right? So you don't have to rush and do anything for malunion. But if the patient is disabled because they can't use their hand because of the finger stiffness, that takes a priority. So in the first scenario, when the patient has just come out of plaster, couple of months later, stiffness, it is not CRPS. You put in the criteria and seen that there is no CRPS, but it's more of fracture disease, what if you want to call it, or like rather plaster disease. And they would do well with mobilization, all the techniques which you want to use, and then take a decision based on the disability whether malunion requires correction. You can't take a decision on malunion correction without the hand function being good. So yes, only if the patient is disabled, then only malunion requires attention, otherwise not. So improve the hand function. Generally, they have shoulder stiffness and hand stiffness, both of them. CRPS is a borderline thing which happens in some patients, and you need to be very, very specific not to slot them into CRPS, and if it was just a plaster disease. So that differentiation has to be careful because your treatment completely differs. So CRPS itself is a big chapter for that for another day, but so that is what is required. And then the last part is when we have situations where because of the implant and everything, there is stiffness developed because tendons are adhered, the gliding is, so this lady, what we have now, she's a teacher, and the fingers, so on table, I did after the tenolysis, gently I manipulated the fingers a little, at least the MCP joints. So now they are quite, and the thumb is moving nicely. She just came for her suture removal and everything. And for me, the balance between, because it's a 2-level osteotomy now, I want to mobilize her early, but at the same time, the gap was there. So there are things which is difficult to take a decision. But in her case, she had a lot of pain and complete restriction of movement of the forearm also. So that's why I went ahead with the osteotomy now. But eventually, her fingers are the ones which will, whatever good job we have done will obviously work if the hand works. So starting our mobilization early now. We just gently manipulated the MCP joints. MCPs are almost coming to 90 now. PIP is a little stiff. Thumb has become mobile after the TPL came out of under the plate. So situations where we know tendon adhesions are there. So there could be a volar plate done and for a distal radius gone into malunion. And you should probably do an ultrasound and see if the FPL and FDS all are adhered there. So different reasons for stiffness, you need to deal with the reason. So plaster disease, CRPS, tendon adhesions, look at what is the cause for stiffness and take a decision.
Yes, sir.
One thing I additionally do in dealing with all this patient is, when under the anesthesia, when we apply the plaster slab, I put a rubber band traction on the finger. So I put the 4 cuff on the finger, put a rubber band traction, and put on the this time safety pin. So under anesthesia, when they get up, come out of anesthesia, they feel there is already 90-degree range of motion. It is, remember that flexion is difficult to come. Extension, even if it's straight out, will come automatically. And definitely correcting the deformity, correcting the malunion, non-union, and manipulating the joint in majority. Say CRPS is extremely rare in Indian scenario. So there, I still remember my professor, Dr. Wolf, used to say in Louisville, to label any patient to be a CRPS is failure to diagnose the etiological factor for your patient's pain, resulting into this complex pathophysiological situation. It may be just a small superficial radial nerve irritation through the K-wire that may be precipitating for the, or maybe a very tight plaster while the assistant holding for the slab application, which is compressing the dorsal sensory branch of the ulnar nerve. Anything, any nerve compression can precipitate this type of situation. If you correct them, majority will get corrected. Yes.
Dr. Shailesh, looking after all these cases, all I can say is, oh my God. And at least I know where to refer my such cases. I just wanted to ask all the learned faculty and other members in the meeting, is there any role of dorsal osteotomies and dorsal grafting, K-wire fixation, which we used to do to treat our malunited distal radius fractures? Do you still do those procedures? And dorsal plating for malunited fracture, is it out or is it still practiced?
Anil, you want to say? I should add.
In my practice, it's not there. So I can do everything on the volar side. I can cover my plate nicely on the volar side. So I would, I know I can tackle most, almost everything on the volar side. So I would not go on the dorsal side. But yes, if you have a low profile plate, you're used to that procedure, you're comfortable with that. I think it's at the end of the day, it's a surgeon's choice, what they are comfortable with. So there's nothing hard and fast that something is in or out. But yeah, looking at the profile of the plate for dorsal side, where you need to have a low profile, would be a good thing for the patient. So that's all I can say.
For me, nothing is in or out. There is nothing like absolute in our practice. So if the volar skin condition is not permittable, some nerve surgery, some volar side vascular surgery has been done, or something where you cannot approach volarly, dorsal is always open. So I have a 2 gate. So one gate is commonly using it, but if it is not possible, I will go from the other side. Nothing like an absolute out, yes, but most of the time I don't require it. So out of 25 cases, only 2 cases I have approached dorsally.
Personally, I had always trouble to correct the dorsal tilt from the volar side. So what I do, I open additionally from the dorsal side, and it is also easier to put the bone graft from the dorsal side, then correct it, and then you can fix either by wires or from the additional volar plate. So
as long as your results are good. There is no,
Yes, ultimately that is what matters.
there is no challenge to it.
The key was what Anil sir told, na? It was a extensile exposure, which is on volar as well as radial side, which helps you to look on the dorsal side also. And then you release the soft tissue on the dorsal side, which is more important. Unless and until the dorsal tissue is released, it won't let you get it correct.
yeah.
I think as long as you respect the soft tissue, you go in tissue plane, nothing is problematic. Nothing is problematic.
But sir, how do you approach? Do you go through the fracture site while releasing dorsally, or through the lateral side, just lateralizing the brachioradialis and go through the lateral side to release the dorsal release through the volar approach? How do you release, or what are your key points which one should consider while approaching through the volar approach?
Both the ways. Depends on how much of additions are there. So my first step would be that I would release the brachioradialis, slightly erase that, and then see how much on the lateral aspect I can go and release this. Once that is done, then I do the osteotomy, and then I distract and see how easily it comes. And if it's still not coming, then I use the osteotomy interval to go in and release a little more of the distal aspect of the distal fragment additions. So it all depends on how, and then the creep phenomenon works. The creep phenomenon is where you would distract, hold it for some time. You know, I showed you that I would put a K wire there just to transfix it, hold it there, and generally the tissues relax. It takes a couple of minutes, but that's what happens. So all these will be used during your surgery in terms of your technique. So primarily brachioradialis has to move away. Then you go a little more on the dorsal side. It's all described. I mean, it's all described. It's a retinaculum. It's basically the entire thing which can be peeled off nicely, and the extensor tendons are outside that kind of a layer there. So that is what is described. You can just gently take it out and use a periosteal elevator, and then go through the osteotomy again, and then the distal fragment can be again released a little, and it usually comes. And I use a laminar spreader there, hold it. Once it distracts, hold it for some time, and then it stays very nicely there. See, the TFCC, the pain, ulnar-sided pain is because either the injury of the TFCC or the TFCC is stretched out when the radial height is reduced and the ulnar height is changed. So this is where the TFCC need not be torn, but still they're all stretched out. The interosseous membrane is all lax, right? So the moment the alignment comes back, and you give them 3 weeks to 6 weeks of immobilization, all of them get their old previous tension back, and that's how this works. So it's not just aligning them and the radius unites. It's not that. It's at the end of the day, the distal radial ulnar joint, the link, what has happened to it, the interosseous membrane, the pronator quadratus, all these fall back nicely, and that is when the carpus starts moving nicely. So this is the secret of that, where you have to get back the alignment, because one, of course, the joint surfaces, the sigmoid notch and the ulnar head have to come back. So Shailesh was telling eyeballing. So that's what happens during surgery. When I'm doing all these, all I'm looking at is what's happening to the DRUJ. Have they come back nicely? And if they have to come back nicely, the inclination and the height has to come. It's not that just the DRUJ comes back and the radius is still sitting somewhere else. No, that can never happen. So you are basically looking at the DRUJ congruency. And once it comes back, the rest of the parameters are taken care of by themselves. And your secondary effect of this is those soft tissues. They all get back there. So the instability in distal radius malunion is only if there's a gross injury to the soft tissues, which most of the time never happens. A direct will not give instability. It gives radioulnar impingement. The stump will go when the pronation and supination happen. The stump goes and impinges onto the radius. So it's never instability as such. Malunited distal radius, again, unless there's a gross TFCC injury which never healed, and there are secondary stabilizers like intraosseous and all have not healed, then only instability comes. Otherwise, pain is the main thing because of these soft tissue injuries. Arthritis is rare again, so they come only much later. So as Shailesh was telling, arthritis patients come, because of so many, they could have had ulnar head fractures, which has gone into arthritis, or they might have had sigmoid notch fractures, which has gone. So then only these people come. Otherwise, they are, because the ulnar head is never in contact with the radius, sigmoid notch, so they would not develop arthritis so early, unless it's also a ulnar head fracture which has happened. So this is how we look at these things in trauma.
Okay, I think we had good discussion, and I will hand over to our secretary, Dr. Rahul Katta sir, to further proceeding.
So thank you, the eminent guest faculty, for their pulse of wisdom on malunited fractures of distal end of radius. I'll request our President-elect, Dr. Jaswant Singh, for the conclusive remarks and vote of thanks.
Thank you very much, Dr. Anil Bhat and Dr. Shailesh, for a very good enlightening talk on this difficult topic, fracture distal radius. And I also thank Madam Patni, Dr. Amit, Dr. Khandaka sir, Dr. Shashi sir, and all the other eminent faculties of Rajasthan for on this difficult topic. And with this, I hand out to Dr. Rahul.
Yeah, thank you so much, sir. So it was a very good discussion, very good presentations. We have learned a lot. So at the end, what I have learned is, until symptomatic and patient is demanding, every patient in malunited lower end of radius do not require surgery. And if you want to do surgery for these malunited fractures, the preoperative planning is very important. So although you can use implant of your choice, but the deformity corrections is very important to find out the results. So selection of case and pre-operative planning is very important to treat such a complex injuries. That's what I have learned today, and I hope everyone has taken home some message, take home message from today's webinar, and will it would be benefited for the future patients when we get these malunited fractures. So thank you all the faculty members, thank you all the panelists, our president, our president-elect, our moderator, Dr. Amit Vyas, and Madam Punya Patni. Thank you. Bye-bye. Stay safe.
Thank you, sir.
Thank you, sir. Thank you so much. Thank you, everyone.
Thank you.
Namaskar. Thank you, everyone.
Thank you, sir.
Thank you, sir. Thank you. Thank you.
Thank you, sir.
ये किसका मोबाइल पड़ा है? किसका मोबाइल है ये? उस मोबाइल है? क्या चीज है? किसका?